all, it's my great honor to be here to discuss my recent work in FD research. Today, my topic is treatment for fibrous dysplasia, RANKL, and beyond. Even though there is a commercial available chemical compound has been used in our study, I have no conflicts of interest to declare. So for people who don't know me yet, please allow me to introduce myself briefly. So I received my BDS PhD from Sichuan University, China. Under a joint training program, I had the opportunity to study in NIDCR and top American universities, and had the opportunity to learn from so many great scientists. Soon after completing a 3 years orthodontic residency training program in University of Pennsylvania, I became a board-certified orthodontist. So one of the most frequently asked questions I received is why a dentist versus doctor got involved in FD research. So first, as Dr. Burke mentioned yesterday, the panoramic X-ray we took during the routine exam actually can review the pathology changes in the craniofacial area. So that placed orthodontists as at the forefront of diagnosing craniofacial FD. Secondly, we moved teeth within the alveolar bone in order to get them straightened and get the bite fixed. So the bone remodeling actually is the biologic basis of the orthodontic tooth movement. A ortho case can take 18 to 24 months or even longer. We want to accelerate the treatment and control the tooth movement precisely by understanding the mechanisms of bone remodeling. GNS and GPCR play an important role in signaling transition and cell functions, including bone development and bone remodeling. That's why bone biology became the focus of my PhD study. Following my mentor, Dr. Goodkind, I was introduced to FD study. So Dr. Goodkind is an expert in GPCR cell signaling and our cancer research. We generated a tissue-specific conditional inducible transgenic mouse model of FD with collaboration with Dr. Yin and Dr. Collins. We proved the FD lesion can happen in embryogenesis if the signal is strong enough. Also, we demonstrated the elevated RANKL expression in the FD lesion associated with the severe bone resorption. Another finding is we proved the human mutant of GNS, specifically R201C here, is not only necessary, is not only sufficient, but also is necessary to initiate and also maintain this disease. As you can tell here, the FD lesions soon reverted and the bone lesion become remineralized upon cessation of the expression of this GNS mutant in our unique transgenic mouse model. Even though it doesn't stand for any specific clinical treatment options currently available, however, it provided an opportunity to study the cellular mechanisms underlying this disease and also provide a platform to test the new drug. Clinical studies demonstrated denosumab, the RANKL antibody, can effectively suppress the progression of FD and the related bone pain. However, some bone turnover rebound and some hypercalcemia will happen to some patients after discontinuation. A lot of things we still don't know yet. In terms of the animal study, same thing, RANKL antibody treatment or any RANKL-related inhibition treatment can effectively suppress the expression of the FD. Data from Dr. Mars and group, and data from right panel is from our mouse model, which is coincident. Still, a lot of questions remain. What is the safer, more effective, and more convenient therapeutic options? As somebody mentioned earlier this morning, the financial burden from denosumab is not a consideration. So, after searching, we found this AS RANKL-induced osteoclastogenesis inhibitor. This is a really long name. Later, I will explain why. So, a couple of advantages of this RANKL inhibitor, in short, is oral bioavailability. Basically, you can just, like eat instead of no needles needed. Of course, robust potency has been demonstrated by quite a few publications so far. So we decided to give it a try on our mouse model. Here comes the data, because I only got 10 minutes, so I will fast forward my data. Basically, this RANKL inhibitor demonstrated robust osteoclastogenesis, both in vivo and in vitro. Only in 2 weeks of treatment of this RANKL inhibitor, we can see the number of the osteoclasts dramatically decreased in the FD lesion. This is a very important slide, because from here we can tell the inhibition of the osteoclast happened without affecting the FD initiating cells in our FD mouse model, which is at the bottom panel, circled in the red. This pretty much reflects the fact in patients, young child, if they still have skeletal stem cells bearing the disease-causing mutations, it's still going to cause the problem if you discontinue the any receptive, driven, targeted therapeutic options, including denosumab and this inhibitor. So, the picture, we can tell the FD mouse model treated by the inhibitor show less swelling. By the way, on top of the question about different promoters we've been used in our research, like Dr. Yin mentioned, the PR-synchry target pretty much at the early stage of the stem cell. So that's why if you check carefully, some FD mice showed some soft tissue edema. I don't think that is part of the FD. Again, this is just mouse model. But it works. The micro-CT scanning reviewed the FD lesions only restricted to the metaphysis area. Doesn't affect the bone shaft area at all. And the bone volume increased with increased BMD. This is a histological analysis, further confirmed previous finding with lower number of the osteoclasts and more mineralized tissue, even within the woven bone area. Unlike in FD mice, we don't see too much TAF3 collagen fibrosis within mice treated with RANKL inhibitor, which indicate less bone damage happened to this mass. Even though you can tell the red colored on the right panel, the type 1 collagen is kind of shorter and more disorganized compared to the white type control. Here is the immunohistochemistry staining. We identified matured lining cells, which were labeled by the positive staining of osteocalcin, rimming the woven bone. That's the direct evidence of remineralization of the FD lesion. And bone turnover rate decreased upon the treatment of the RANKL inhibitor. Let's check the bone strength. The compression test was performed on the hand limb, which is a weight-bearing bone. results show their stiffness, the resilience got increased dramatically. So this is the video we took at the T3, which is the endpoint of this in vivo experiment. You can tell without labeling, probably you cannot tell which one is wild-type control, which one is FD RANKL inhibitor treated FD like mouse. Basically, we rescued the mobile capability of FD mouse using this RANKL inhibitor. On the other side, in the contrast, FD mouse couldn't move at all because we relatively used a higher dose of DOX. Basically, a lot of bone fracture and bone pain. It's poor mouse. Next, we are planning to perform comprehensive safety study about this drug. So far, we observed no significant change in terms of the serum electrolytes. But not surprisingly, as I mentioned before, once we discontinue this drug, then there is a recurrence of this FD disease because the presence of FD-initiating cells with the presence of DOX. So we don't know the mechanism of this drug because the name cited from the paper is a RANKL-induced osteoclastogenesis inhibitor. It's purely phenotype-driven screening. And we try to study the mechanism of this drug and also try to design new drugs based on their therapeutic target. So far, collaborating with chemistry expert, we've been identified a couple of candidates. And time is up, so I'd like to thank ICFDMAS organizations for having me here, and also I want to thank the invaluable trust from my patients and direct donation from them. And I would like to thank all those grant opportunities and collaborations. Thank you so much.